In this week's lecture presentation, we'll be looking at the relationship between stress, pain, depression, and addiction, which aligns with Robert Sapolsky's Why Zebras Don't Get Ulcers, chapters 9, 14, and 16. As always, I recommend having the slides nearby so you can take notes as we proceed through the lecture, and also the interactive study guide so you can complete the questions as we move along. Before we look at the connection between stress and pain, I want to review some of the stress physiology concepts as they relate to individual vulnerability to stress. First, at baseline, which is at rest, cortisol levels compared to stress-induced cortisol release. It appears that the most resilient individuals are those who have high baseline levels of cortisol and low stress-induced cortisol release. This is associated with less hyperactivity of the stress circuits, and again, is associated with increased resilience. Conversely, low baseline cortisol and high stress-induced cortisol release is a sign of increased hyperactivity of stress circuits and therefore to less resilience. Another factor that relates to the individual vulnerability to stress are early life experiences. Early stressors can alter the functioning of the hypothalamic pituitary adrenal axis. This can lead to hyperactive hormonal responses throughout the lifespan, including increased activity of corticotropin-releasing hormone in the amygdala and the hypothalamus, which we've learned previously is associated with an overactive SAM and HPA stress response. Additionally, low glucocorticoid receptors in the hippocampus does cause an impaired feedback loop in terms of the HPA system. That means that because there are fewer glucocorticoid receptors, the ability of those receptors to send the feedback signal to slow down is impaired, and therefore the individual is slower to recover from HPA activity. Another factor is prolonged stress. When it comes to prolonged stress, we see an increase of glucocorticoids over long periods of time, which eventually can change both brain structure and function. Two areas where this is particularly notable are the hippocampus and the amygdala, where they actually have opposite effects. In terms of the hippocampus, we see less neurogenesis, that is the creation of new neurons, less synaptogenesis, the connection between those neurons, and less arborization, the dendritic trees and spines that branch off from the dendrites and from the soma. These changes are associated with a decrease in the ability towards contextual learning. That's because one of the primary responsibilities of the hippocampus is to consolidate new memories. When that is impaired, the individual will have difficulty with contextual learning, which can lead to a difficulty in distinguishing the appropriate context for various responses. That is, there's a tendency to generalize these triggers, such that the individual will respond to a wider range of triggers in the future, and therefore will experience even more stress reactivity. The amygdala experiences the opposite effect. Rather than a reduction, the amygdala undergoes increased arborization and synaptogenesis. This leads to increased fear conditioning because it is one of the primary responsibilities of the amygdala to help the individual learn about fearful and anxiety-producing situations. This is also associated with increased activity of the behavioral inhibition system, which, as we've learned, is associated with avoidance motivation. Additionally, a hyperactive amygdala requires higher than usual glucocorticoid responses in order to recover. So this can also impair the ability of the body to recover from stress-induced changes. We'll talk about this a bit later, but I want to mention here as well that the prefrontal cortex also is impacted by prolonged stress, and it shows a decrease in dendritic connections, which impairs the ability to control limbic areas. The specific brain-related changes vary according to the timing of the stressor. Hippocampal volume is more impacted by early childhood stressors, particularly abuse. whereas the prefrontal cortex impact is more likely to occur later into development, such as during adolescence. Biological sex and hormonal fluctuations also impact the stress response. It appears that high estrogen, particularly following childbirth and variations throughout the menstrual cycle, can lead to stress-induced glucocorticoid release at higher levels than might be typical for that individual. This also increases that individual's sensitivity to stress and may explain the increase in incidence in mood disorders and other challenges following childbirth and during hormonal changes throughout the lifespan. We'll talk about the relationship between stress and pain on the next slide, but first I want to discuss some terminology related to pain. For those of you who like to pause the lecture recording to watch the videos, you might pause here to watch the video, This is Your Brain on Pain. The first term that's important to know in terms of pain is nociceptor. Nociceptors are pain receptors. They are free nerve endings at the skin that start from the spinal cord and terminate at the skin. That way, they can pick up pain and other sensory information and transmit that information to the spinal cord and up to the brain. There are two main fibers when it comes to pain, fast fibers and slow fibers. Fast fibers are A fibers, and they're meant to transmit sharp and sudden pain. These fibers are heavily myelinated so that they can facilitate a very quick response to a painful stimulus. They operate by inhibiting interneurons. That is why individuals might experience pain followed by relief. There's an initial source of pain, but then the inhibition occurs, which relieves the person from pain, at least temporarily. That's where the C fibers come in. These slow fibers are meant for slow, burning, throbbing, aching type pain. Rather than having a fast transmission of signal, these slow fibers actually transmit information much more slowly. Fast fibers are meant to send a signal to say, stop what you're doing immediately. For example, if you were cutting a tomato and started to cut your finger, the difference in a second could be the difference between an unfortunate cut and losing your fingertip. Whereas fast fibers are meant to give you sudden and quick information so you can stop what you're doing, slow fibers are meant to encourage rest and immobilization. This would be akin to a sprained ankle that aches over time. The goal, as far as your body is concerned, is for you to stop walking on it so it can heal. Slow fibers operate in response to a painful signal by blocking inhibitory interneurons. That means that the pain lasts because the inhibition is blocked. One interesting thing that I want you to think about briefly is, why do we massage or itch around, for example, a bug bite? Oftentimes we find that it helps with pain. The reason for this is that it activates A fibers, which then inhibit the C fibers, so that you can experience some temporary relief due to the inhibition of C fibers that typically inhibit that interneuron that inhibits pain. All things considered, essentially what it does is it creates a signal that transmits on the fast A fiber that then leads to a brief moment of inhibition so that you experience a bit of pain relief before those C fibers become active again. Two other important terms to know when it comes to pain are analgesia and allodynia. The next important term to know is allodynia, which refers to pain that occurs in response to a typically non-painful stimulus. This will appear like an overreaction to pain to somebody who is not in that individual's body, because while the stimulus is not typically associated with that degree of pain, the individual experiences it that way. Allodynia is due to inflammation around the site of injury in many cases. That enlarges the area of pain and can directly cause neuronal damage. From here, inflammation essentially releases regenerative growth factors that encourages these fibers to rewire in tangles, which are known as neuromas. That increases pain for the individual. Essentially, a neuroma is a tangle of nerve endings that are extremely hyperexcitable and send increased pain signals to the spinal cord. Diabetic neuropathy is pain that is caused by atherosclerotic plaque-induced damage to blood vessels, which results in decreased blood flow and decreased energy. These damaged blood vessels, which have decreased blood flow and decreased energy to nearby nerves, result in inhibitory interneuron damage that therefore leads to increased pain over time because the interneurons cannot do their job in inhibiting pain signals. Therefore, what should be transient pain becomes throbbing, longer-term pain. So how does stress play into the pain puzzle? First off, I want to note that activation of pain receptors doesn't necessarily correlate with the experience of pain. How we feel about that pain, how we think about that pain, and other things going on in our lives, particularly emotionally and psychologically, can alter our response to pain in terms of its transmission up and down the spinal cord. One line of evidence of this is that placebo effects work for pain, but when individuals take a medication known as naloxone that blocks the opioid receptor, they actually end up blocking the pain-relieving placebo effects. Therefore, our experience of pain appears to be related to opioid activity at the receptors. Stress can lead to increased or decreased sensations of pain. Stress-induced analgesia refers to individuals who, under stress, experience less pain than you might expect. This tends to be short-lived, and it tends to be related to survival. What happens here is that stress leads to increased release of endogenous opioids, such as enkephalins and endorphins. These activate descending pathways that blunt sensitivity of A fibers to pain. Females, compared to males, are more likely to experience this effect in response to exercise of any kind, whereas males tend to need a competitive spirit with that exercise in order to activate the same degree of opioid activity. This is a short-term response. The body will eventually run low on its endogenous opioid supply, and therefore the analgesic effect will wear off. The contrast to stress-induced analgesia is stress-induced hyperalgesia. Hyperalgesia is more associated with emotional worry and stress. Things like, what's wrong with me? How long is this going to last? I can't handle this. I can't take this any longer. That tends to be associated with more hyper pain or hyperalgesia. This is related to increased emotional reactivity to pain, and the evidence for this is that anxiolytics, like benzodiazepines such as Xanax and Valium, actually block stress-induced analgesia. Moreover, high scorers on measures of neuroticism and anxiety appear to undergo more stress-induced hyperalgesia compared to individuals who are less neurotic and less anxious. There also appears to be a relationship with fibromyalgia here, and the current investigation is looking at the role of substance P. It appears that higher levels of substance P are associated with higher sensitivity to pain. Another factor that influences pain response and pain tolerance are natural endorphin levels. Individuals with higher levels of endogenous opioids tend to have higher pain tolerances. And again, that's because opioids activate those descending pathways that blunt sensitivity of A fibers to pain. It's also important to consider the impact of tense muscles and lifestyle factors, both of which are heavily influenced by stress. The person may be more inactive, may be overly protective of an area of the body, may eat comfort food, may miss out on social events, etc. There are a lot of ways in which increased stress can lead indirectly to pain as well. Just as there are many influences in terms of the perception of pain, there are also many influences in terms of mood dysregulation that can increase the risk of developing depression. The risks for major depressive disorder are important to understand, particularly in light of its prevalence and its consequences. It is the leading cause of disability in the United States for ages 15 to 44 and affects 6.7% of the U.S. adult population. One factor that contributes to mood dysregulation is epigenetics. Epigenetics, as we've discussed previously, refers to changes in gene expression based on experience. Genes are turned on or off in response to what we experience in life. A live brain is a changing brain, which really speaks to the importance of emotional enrichment and development and the profound impact that early life experiences have on mental and physical health throughout the lifespan. Genes increase the risk of depression only in stressful environments. Again, this speaks to the epigenetic principle of the interaction between experience and genetics. Predispositions can increase vulnerability to depression in response to major stressors, and that vulnerability may be related to the stress response in terms of intensity and the ability to rebound. The connection between epigenetics and the risk for depression is explored in the video this week, which is How Chronic Stress Affects the Brain. I recommend viewing the video now before proceeding with the lecture. There are two polymorphisms that are associated with the vulnerability to depression. These include the polymorphism for the serotonin transporter and for BDNF. In terms of the serotonin transporter, individuals with the short allele tend to have a less effective transporter in terms of its ability to modulate serotonin. This less effective transporter cannot respond effectively to stress-induced serotonin release. Therefore, these individuals are more vulnerable to depression if they are exposed to chronically stressful life events. This is especially true if they are homozygous for the short allele. BDNF stands for brain-derived neurotrophic factor and can be thought of as brain fertilizer, as it nourishes cells to be functional and increases dendritic spine density, which is associated with increased potential for synaptogenesis. Individuals who have low levels of BDNF tend to experience less neuroplasticity, which means their brains are not as able to respond to experience as individuals who do have more potential for neuroplasticity. Some good news here: exercise is linked to positive epigenetic changes, particularly in terms of BDNF activity. Even mild exercise, like a brisk walk, where 30 to 40% of O2 max for about 30 to 45 minutes, can lead to increased activity of BDNF that facilitates increased neurogenesis. That means if you're getting your 10,000 steps a day, you're doing something really helpful, not only for your body, but for your brain as well. From an epigenetic perspective, lack of predictability of care tends to be one of the major childhood risk factors, which is particularly likely to affect individuals who are raised in low socioeconomic status environments and/or who belong to marginalized groups. Another factor that can increase or decrease an individual's susceptibility to mood dysregulation is their sensitivity to low serotonin activity in the central nervous system, as well as the distribution of serotonin 1A versus 2A receptors. There are at least 14 different serotonin receptors, all of which are metabotropic, except serotonin 3. Serotonin activity and the distribution of receptors is strongly linked to an individual's vulnerability towards depression as well as anxiety. Sensitivity to low serotonin in the brain is a particularly strong vulnerability factor for depression. It's also associated with irritability and aggression, increased pain sensitivity, modified anxiety-related behaviors, and altered eating and satiety. It does not directly cause depression, but it does appear to be a strong factor in terms of an individual's vulnerability. Let's talk about the 1A and the 2A receptor. High levels of the serotonin 1A postsynaptic receptor, which are primarily located in the forebrain and in glial cells, are associated with a protective factor against depression. However, high levels of serotonin 1A autoreceptors are a risk factor for depression. As we've discussed previously, postsynaptic receptors are related to what happens in the neighboring cell, whereas autoreceptors are a feedback mechanism for the presynaptic cell, So high density of 1A autoreceptors means that they'll get more signals to slow down or to stop release of serotonin compared to low levels of autoreceptors. The serotonin 2A receptor, which postsynaptically is located in the cerebral cortex and the basal ganglia, is also associated with the higher risk for depression. Therefore, higher density of the serotonin 1A autoreceptor and/or higher density of the serotonin 2A postsynaptic receptor are both considered risk factors for depression, particularly if the individual has high levels of both. Hormones are also related to an individual's susceptibility to mood issues. Estrogen and progesterone help regulate the metabolism of norepinephrine and serotonin, both of which have been implicated in depressive disorders. During hormonal fluctuations, an individual is more likely to experience mood dysregulation, and this has to do with an abnormal ratio of estrogen to progesterone. Women experience hormonal fluctuations throughout the lifespan, during menstruation, pregnancy, post-pregnancy, menopause, and in response to hormonal birth controls. High levels of estrogen lead to higher levels of stress-induced glucocorticoid release, which, as we know, increases the individual's sensitivity to stress. After puberty, females have a 1.5 to 3 times higher reported rate of depression. Women are more likely to develop depression and to have more depressive episodes in the case of bipolar disorder. Now, there are likely psychosocial contributing factors here as well, such as the lack of power and control or the subordinate role that women play in society compared to men, but it appears that these hormonal fluctuations are playing a role as well. Lastly, physical health and lifestyle factors. Vascular issues, inflammation, and chronic pain are all associated with an increased risk of depression. This might represent a cause and effect relationship, or an underlying variable that increases the risk of any of these outcomes. Additionally, factors like the degree and the type and the intensity of exercise, an individual's diet, their sleep habits, their degree of sociality and social connection, and mindfulness can all increase or decrease a person's risk for depression and anxiety. Good quality exercise, diet, sleep, social connections, and mindfulness have all been shown to be pretty powerful protective factors against depression and anxiety. In terms of sleep, disturbances in the circadian rhythm have been linked to depression. Unhealthy lifestyle and poor physical health that increases the risk of vascular issues and chronic inflammation are also associated with increased risk. These daily activities are very important in terms of preventing and/or increasing the risk of mood issues over the lifespan. The first few episodes of depression tend to be triggered by significant stressors. Vulnerability to depression may relate to the individual's ability to rebound from stress. Interestingly, the fourth and later episodes of depression appear to be independent of stressors. One of the factors that influence the stress and depression link are stress-induced neurochemical abnormalities, particularly in terms of the neurotransmitters dopamine, norepinephrine, and serotonin. Stress leads to depletion of dopamine from the mesolimbic tract and from the locus ceruleus in terms of norepinephrine. It also affects the synthesis, release, efficacy, and breakdown of serotonin. Typical forms of depression are also linked to higher than usual glucocorticoid levels. Sustained stress, particularly when there is lack of control or lack of an effective outlet, are linked to depression. Stress-induced decreases in the sensitivity of the glucocorticoid system to feedback regulation can eventually lead to decreases in the effectiveness at the body's ability to shut down glucocorticoid secretion. Initially, glucocorticoids can lead to a sense of euphoria and even mania, but over time, as this is depleted, the individual is more likely to experience depression. Atypical depression, in particular, is associated with lower than usual glucocorticoid levels. The link between chronic immune activation and depression has been partially evidenced by individuals' responses to cytokines. Cytokines are linked to depression in animal and human models. Cancers that are treated with cytokines, because of their ability to enhance immune functioning, often result in depression. Cytokines stimulate not only CRH release, but also interact with norepinephrine, dopamine, and serotonin. Therefore, stress directly and indirectly via glucocorticoids affects serotonin, norepinephrine, and dopamine systems. The hippocampus and the frontal cortex, as we've discussed previously, are particularly vulnerable to stress-induced damage. A high number and high sensitivity of glucocorticoid receptors in both of these brain regions are associated with its increased vulnerability to volume loss in those areas. The hippocampal volume loss is due to death and/or damage to neurons, inhibition of neurogenesis, or both. Hippocampal volume loss due to death and damage of neurons is associated with impaired declarative memory. Frontal cortex volume, on the other hand, appears to be related to a reduction in glial cells. The volume loss in both the hippocampus and the frontal cortex may be permanent. As I mentioned earlier, the amygdala undergoes a different response than the hippocampus and the frontal cortex, in that the amygdala becomes more arborized and more dense over time. This also occurs with the anterior cingulate cortex. The functional response to increased density of the amygdala is exaggerated activation in response to something sad. Rather than being primarily motivated by fear, the amygdala begins to respond to signs of sadness. Moreover, the anterior cingulate cortex, which also has higher than usual activity, increases the focus on quote-unquote negative emotions. When you electrically stimulate the anterior cingulate cortex, the individual experiences sadness, fear, foreboding, and emotional pain, all of which are associated with depression. So let's bring this together and talk about the neurobiology of depression. As stated previously, early trauma may change the set point for the HPA axis, making it permanently over-responsive, which is associated with an increased risk of depression, anxiety, and substance abuse, which we'll talk about next. Let's start with the amygdala. Individuals who have experienced early life trauma tend to have more amygdala reactivity, that is, overstimulation of the CRH circuit. Basically, high levels of stress lead to high levels of dendritic arborization in the amygdala, which makes it overreactive. In contrast, the hippocampus, which undergoes volume loss over time in response to chronic stress, is supposed to be part of the feedback circuit for the stress response. Glucocorticoid receptors located in the hippocampus are supposed to send the slowdown signal when glucocorticoids bind to those receptors. When there are high levels of glucocorticoids and there therefore damage to the hippocampus and the prefrontal cortex, the brain loses its ability to effectively inhibit HPA activity. Therefore, there's hypersecretion of CRH by the hypothalamus. High CRH activity leads to high ACTH activity from the pituitary gland, which increases glucocorticoid release. And again, these individuals also less sensitive to hippocampal inhibition in response to increased glucocorticoids. Chronically elevated glucocorticoids lead to many pathological changes, including reduced immune functioning, hippocampal atrophy, cognitive impairment, and serotonin dysregulation. Typical forms of depression are linked to higher than usual glucocorticoid levels, and as stated earlier, atypical depression with lower than usual glucocorticoid levels. Atypical depression is a depression that temporarily lifts in response to good news or positive events. It's associated with sleeping too much, but still feeling sleepy in the daytime. A heavy, leaden feeling in arms and legs that lasts an hour or more each day. And pronounced sensitivity to rejection or criticism, which affects the individual's relationships, social life, or employment. I've mentioned BDNF as a polymorphism that can affect an individual's vulnerability to depression. So let's talk about that a little bit more. The gene for BDNF is located on chromosome 11. The BDNF SNP is built with methionine or valine. Individuals who have the valine-valine combination tend to be the most neurotic. They have the lowest mood, the highest anxiety, and the most hostility. These individuals are at the highest risk for mood disorders compared to individuals who have a valine-methionine or methionine-methionine. The BDNF gene polymorphism is a risk factor for mood disorders, not necessarily depression. And again, this appears to be related to epigenetic changes more than strictly genes. Low BDNF activity contributes to neuronal damage in the hippocampus and the prefrontal cortex. It is associated with fewer dendritic spines in these areas, which leads to limited plasticity, memory impairment, executive dysfunction, and limited control over the limbic areas, which means more emotional lability. Lack of cortical control over limbic structures is associated with vulnerability to stress and depression. It's very important that the prefrontal cortex is able to control the limbic regions. Otherwise, the individual is likely to experience high levels of impulsivity, cognitive impairment, anhedonia, and emotional dysregulation and reactivity. There is also functional imbalances in brain activity that is noted in individuals with depression. One of these is less activity of the left prefrontal cortex, which is associated with positive mood, and higher activity of the right prefrontal cortex, which is associated with quote-unquote negative mood. Lower activity in the dorsal lateral prefrontal cortex is associated with less reappraisal and less suppression of negativity, compared to higher levels of activity in the ventromedial prefrontal cortex, which is associated with rumination, a common symptom of depression. Moreover, higher activity in the medial orbitofrontal cortex is associated with trying to control unpleasant thoughts and feelings, oftentimes an attempt that is not successful. And the anterior cingulate cortex, which mentioned earlier, relates to emotional pain, as well as sadness, fear, and foreboding. Unfortunately, one common way that people attempt to cope with pain and depression is with substance use. Substances are very commonly used in U.S. society. All of the statistics presented on this slide are U.S. statistics, with research that is based on SAMHSA and the National Survey of Drug Use and Health. 8.5% of the U.S. population over the age of 12 met criteria for a substance use disorder in 2012. The research shows that alcohol is the most commonly used and abused psychoactive substance in U.S. society, followed in order by nicotine, marijuana, and pain relievers. A staggering statistic is that the United States makes up only 4.6% of the world population, but uses 80% of all of the world's prescription opioids. Just over 50% of Americans 12 or older reported being consumers of alcohol currently. That is 135.5 million current alcohol consumers. Nearly 25% of people aged 12 or older reported binging on alcohol in the last 30 days, and an estimated 14.9 million adults were classified as alcohol dependent. Tobacco is used by 69.5 million individuals 12 or over, which represents 26.7% of that population. The age group 18 to 25 is by far the highest users of all substances across the board. Discrimination increases the risk of substance use and abuse, particularly alcohol abuse in women and drug abuse in men. Unfortunately, 40 to 70% of individuals who enter treatment for a substance use disorder will relapse within 1 year. Fortunately, medications can help the user resist and/or manage use, and we'll briefly discuss some of these medications at the end of this lecture presentation. As mentioned earlier, there are also biological and psychosocial factors that contribute to the risk of developing a substance use disorder. On a biological level, genetics, dopamine and endogenous opioid levels and responses, as well as dependence and tolerance, all play a role in the risk. Psychosocially, the degree and effectiveness of coping skills, the experience of stress, trauma, and discrimination, and various forms of learning, such as classical conditioning, operant learning, and social learning, all contribute as well. There's also a link to comorbidities, which are co-occurring disorders. For example, unmanaged ADHD, depression, anxiety, PTSD, and OCD are all associated with an increased risk of coping with substances, which increase the risk of developing a substance use disorder. The reward circuit in the brain can be activated by alcohol and drugs of abuse, as well as non-drugs, such as sugar, shopping, sex, gambling, and video games. The reward circuit mediates the acute rewarding and reinforcing effects of abused drugs. This involves both the mesocortical and mesolimbic pathways. Mesocortical pathway is from the ventral tegmental area to the prefrontal cortex, and primarily regulates executive functioning, compared to the mesolimbic pathway, which also originates in the ventral tegmental area, but terminates in the nucleus accumbens. This pathway is associated with reward, pleasure, and reinforcement. Animal studies have proven that dopamine is not the only contributor to the sense of reward and reinforcement. Instead, opioids also appear to play a powerful role in the reward anticipation and reward response. In an absence of dopamine, animals still seek out and respond to rewards. Dopamine is released in anticipation of reward and to a lesser degree in response to the reward itself. Pleasure is more about appetite than satiation. The appetitive stage, which relates to the anticipation related to the expectation of pleasure, is the foundation of goal-directed behavior. The possibility of reward is linked to the biggest response and is intermittently reinforced. The consumatory stage involves the response to the reward itself. The switch from how good a drug feels, which is positive reinforcement, to how bad the absence of a drug feels, which promotes use via negative reinforcement, is a sign that the individual is moving towards a substance use disorder and is certainly a risk factor for the development of a use disorder. There is neurochemical variance depending on the drug that is used. Alcohol, which enhances GABA, also leads to increased release of dopamine in the nucleus accumbens, as well as opioids in the ventral tegmental area, nucleus accumbens, and amygdala. Opioids activate opioid receptors in the ventral tegmental area, nucleus accumbens, and amygdala, and also increase dopamine activity in the nucleus accumbens as well. Keep in mind that we also get a dopamine rush and potentially an opioid rush from high sensation activities in general. But this only occurs if these activities are within our control, short-lived, and have a high likelihood of a positive outcome, that is, relatively safe. It's the difference between going to Not Scary Farm or being stalked for real. Moving on to the stress and addiction link. Stress increases the likelihood of initial substance use, addiction, and risk of relapse once abstinent. Short-term moderate glucocorticoid release triggers dopamine from the pleasure pathways. That means that acute stress actually increases the reinforcing potential of a substance or activity. Higher dopamine release leads to higher degrees of anticipation and reward. As we've discussed many times, early life stress increases the risk of HPA dysregulation, which then increases the risk of drug use and abuse. The self-medication hypothesis refers to the fact that individuals might use substances to medicate themselves, that is, to help reduce symptoms of whatever they are experiencing. These individuals also tend to have changes in their stress response system, that is, HPA dysregulation, that relates oftentimes to early childhood stressors. Higher reactivity to stress increases the likelihood of a pleasurable response to a substance. In these cases, glucocorticoids are released for longer than usual periods of time, which means more dopamine is released, which leads to more pleasure and more learning. There's also more transient activation of the amygdala that is associated with increased dopamine release, as well as activation of the sympathetic nervous system that increases glucose and oxygen flow to the brain that leaves the person feeling more alert, alive, motivated, and stimulated, which is quite positively reinforcing for most people. Eventually, with sustained use, the stress response is blunted, both physiologically as well as cognitively. On the way to addiction, individuals will experience increased physiological and psychological dependence and tolerance. Dependence refers to adaptation to a substance. It is essentially the body's adjustment to the presence of the substance that allows for homeostasis. Many medications taken daily are dependence-inducing. That does not mean that they're necessarily habit-forming. Dependence can be physical, which is biological, and/or psychological, which is more cognitive in nature. Physical dependence can be evidenced by withdrawal symptoms. Psychological dependence is more so related to the individual's beliefs about needing the substance. You can be physically dependent without being psychologically dependent, and you can be psychologically dependent without being physically dependent. But it happens to be that oftentimes they both co-occur together. Again, if the person is physically dependent on the substance, when they discontinue that substance, they are very likely to experience withdrawal effects, and those symptoms tend to be opposite of the acute effects of that substance. For example, an individual who is withdrawing from a stimulant may feel more tired than usual, more hungry than usual, and perhaps even less able to focus than usual. Physical adaptation is based primarily on metabolic and cellular adaptation. So again, you can have evidence of tolerance and withdrawal and not be addicted. Physical adaptation is a sign that your body has adapted to the substance, not that you think that you need it. Tolerance refers to reduced responsiveness to the same dose of a substance, and there are many forms of tolerance. Cross-tolerance refers to tolerance that is developed because of a similar substance. For example, there is cross-tolerance between alcohol and benzodiazepines. Metabolic tolerance is tolerance that is developed because of increased activity of the metabolic pathway of that substance, oftentimes in the form of upregulated liver enzymes. Cellular tolerance is also referred to as pharmacodynamic tolerance and refers to changes at the cellular level, for example, downregulation and desensitization of receptors, or conversely, upregulation and increased sensitivity of receptors. Behavioral tolerance is based on learning and involves changes that occur in responses to cues. For example, if an individual always uses their drug of choice after work in their living room, their body begins to prepare as they travel home from work and walk into their home. They know that that drug is coming. The body, therefore, protects itself by becoming additionally prepared for that substance. This can lead to an increased risk of overdose if the individual uses in an unfamiliar environment or at a different time than usual when the body is less prepared. It also helps to explain why individuals who go wine tasting during the day or have champagne at brunch oftentimes will experience more intoxication than they might drinking the same amount of alcohol at a bar on a Saturday night. Addiction is the compulsive use of a substance despite negative consequences. In order to qualify as an addiction, it needs to be causing problems in the individual's life. Addiction involves the reward circuit and increases in dopamine, particularly in the nucleus accumbens. Habit-forming substances are associated with an effect that is highly desired by the user, which can be quite subjective in nature. Some drugs are generally found to be more habit-forming than others. For example, opioids, alcohol, stimulants, and nicotine are highly addictive. In terms of medications, anxiolytics, opioid painkillers, sleep medications, and stimulants tend to be the most habit-forming. With that said, anything could be habit-forming to the right person. For example, some people abuse Seroquel, an antipsychotic medication that most people wouldn't abuse because some people like the sedating quality that comes with Seroquel's use. This is particularly prevalent in settings where individuals cannot access other substances, for example, in a juvenile hall setting. The transition from substance use to substance abuse to substance addiction is oftentimes the switch from primarily motivated by positive reinforcement to negative reinforcement. Early on, drug use tends to be about anticipation or wanting, but later on, there's a transition to a sense of needing the substance, which is oftentimes motivated by low dopamine levels due to the chronic drug use. The switch from primarily positive reinforcement, where individuals are likely to use a drug again in the future because of the pleasure they experience, to negative reinforcement, where the person is motivated to use again to relieve themselves of the distress, generally due to the withdrawal symptoms, is a major risk factor and common feature of the progression to addiction. As time goes on, and the individual has higher and higher levels of tolerance, they will no longer experience the same high or rush that they did earlier in their drug use. That means that they have to use more and more of the substance, not only to experience any effect, but to relieve themselves of the withdrawal in general. Another factor that plays a role in the transition to addiction is cue-elicited craving, which refers to craving that is prompted by cues in the environment that remind the person of their desire to use. The more cue-elicited craving the individual experiences, the higher their risk of context-dependent relapse. It could be something as small as driving by an open sign on a bar that reminds the person of how much they used to love drinking and might inspire craving. These learning pathways have been potentiated, that is, strengthened, in certain settings in particular, which leads to an anticipatory surge of dopamine that encourages the person to not only experience craving, but to satisfy that craving as well. Self-administered substances with fast-acting and or short-lived effects are the most likely to be abused. Therefore, it is the safest approach to administer medication or prescribe that medication on a timed schedule and to use medications that either have a slow onset and or a long-acting effect. Ultimately, addiction is maintained by an increase in go or compulsivity, that habitual, automated sensation of needing the substance, and less of the ability to stop, that is, higher craving and more impulsivity and less prefrontal control over time. Of course, psychosocial factors also play a large role, including the degree of coping skills, the meaning and purpose the individual derives from their daily life, their sense of social connection and support, peer and familial influences, experiences of trauma, and comorbid mental health conditions. There are a lot of biological approaches to the treatment of chronic pain, depression, and substance use disorders. Interestingly, antidepressants are used for all three of these conditions in many cases. This is only a brief overview and a few examples. I do want to point out that there are many other options for all of these conditions, including opioid pain medications, GABA agonists, muscle relaxers, benzodiazepines, and other substance abuse medications as well. Antidepressants affect some combination of serotonin, norepinephrine, and dopamine. All antidepressants affect serotonin with the exception of bupropion, which is brand name Wellbutrin, which is a norepinephrine dopamine reuptake inhibitor. There are two common approaches to antidepressants: enzyme inhibition and reuptake inhibition. Enzyme inhibition, for example, MAOIs, work by blocking the enzyme MAO, which typically breaks down the monoamines, serotonin, norepinephrine, and dopamine. Therefore, more is available in the synapse. Reuptake inhibition has a similar outcome, but a different mechanism of action. Reuptake is the process of a transporter protein bringing the neurotransmitter back to the neuron that released it. Reuptake inhibition, therefore, is blocking that transporter from doing its job, which leads the neurotransmitter or neurotransmitters in the synapse for a longer period of time and therefore more of a chance to go and affect their neighboring cells. This includes tricyclic antidepressants, SSRIs, which stands for selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, and as mentioned previously, Wellbutrin, which is a norepinephrine dopamine reuptake inhibitor. The timing of antidepressants is usually about 4 to 6 weeks after an individual begins before they experience a significant change in their mood. This is likely related to the time it takes for the autoreceptor to downregulate. Again, the autoreceptor's job is to send a message to the neuron that says, "We have enough." Medications like SSRIs, because they lead to increased availability of serotonin, begin to bombard the autoreceptor. The brain responds by downregulating the autoreceptor to compensate for the increased activity of serotonin. Over time, because there are fewer autoreceptors, there are less signals to slow down production. That means at about 4 to 6 weeks after taking the medication daily, there should be an increase in production of those neurotransmitters. Antidepressants also appear to increase the activity of BDNF, which may correct the volume loss in the hippocampus and frontal cortex and may also align with the delayed timing of the efficacy of antidepressant medications. Vegetative symptoms suggest stronger biological components and seem to be a sign that the individual may be a better candidate for medications. This includes reduced appetite, early morning wakening, poorer mood in the morning, fatigue, and concentration issues. Since about half of depressed individuals have elevated glucocorticoid levels, it's been suggested that perhaps antidepressants only work in the first few rounds of depression, or only for some people. It has been suggested that perhaps antidepressants ultimately treat abnormal neurochemistry that then reduces stress, which reduces glucocorticoid levels to normal levels. The majority of substance use disorder pharmacotherapy options involve reducing withdrawal and/or affecting craving. There are many different options, and these are just a few. Acamprosate, which is brand name Camprol, is a partial NMDA glutamate antagonist. It also enhances GABA. This helps support abstinence, particularly from alcohol, because it reduces withdrawal by giving the person a little bit more of the GABA activity and a little bit less of the glutamate activity, which is more similar to what alcohol provides. Naltrexone, which is brand name Revia, Depade, or Vivitrol in the injection formulation, is a mu-opioid antagonist. It is linked to decreased craving and reinforcement, but unlike opioids, is not associated with any experience of a high. Naltrexone is similar to the medication naloxone, which is also an opioid competitive antagonist. But unlike naloxone, it takes a little bit longer to take effect, which therefore makes it less effective in an overdose situation, and also lasts longer, which makes it a better choice for a daily medication. Naltrexone is used for alcohol use disorders and opioid use disorders. It can actually be used when an individual is actively drinking, which is known as the Sinclair method, and prior to a complete detox. However, it should not be used while an individual is actively using opioids because it will cause an intense and abrupt withdrawal, which could promote craving and lead to an increased risk of overdose. Buprenorphine, which is brand name Subutex, Buprenex, Butrans, and Belbuca, is a mild and longer-lasting opioid partial agonist. This is akin to giving the individual a milder version of the problem opioid. Probufene, which is an implantable option that delivers buprenorphine for up to 6 months, which can be nice because it leads to a controlled dose and higher compliance. Suboxone contains buprenorphine, but it is combined with naloxone. It's typically available in a sublingual formulation to minimize abuse. Also, don't underestimate the importance of psychosocial approaches, too. Regular exercise, talk therapy, finding meaning and purpose, social connection, gratitude, generosity, and a host of other psychosocial approaches are extremely effective for pain, depression, and substance use disorders. There are also medications that affect the stress response, but at this point they're not widely used. This includes adrenal steroid dehydrogenesis inhibitors that only work if there are high glucocorticoid levels, and are also associated with a heavy list of side effects. DHEA, which is a hormone that blocks glucocorticoid access to its receptors and therefore limits the stress response, is also being looked at as a potential medication that may be useful for these conditions. In treatment-resistant cases, electrical convulsive therapy, transcranial magnetic stimulation, and a cingulotomy where they lesion the anterior cingulate cortex to deactivate it may also be considered as an approach to treatment if other approaches have not been successful and the individual is in desperate need of relief. Now that we've concluded the lecture presentation, I recommend viewing the final video of the week, which explores Johann Hari's views of addiction in his TED Talk, entitled "Everything You Think You Know About Addiction Is Wrong."